Right, I think I'll just get started. I'm Mark Schumacher, the director for the Pain and Addiction Research Center here, along with many exciting colleagues. PARC is a transdisciplinary center spanning UCSF's both clinical and research communities to really try to find common intersections in pain and addiction science and care. There's a QR code if you'd like to be directed to our website and consider membership. Just a couple quick announcements. Next month, our upcoming Park seminar, Dr. Chris Albrecht, in our pain division, will be doing a patient interview and focus on outpatient ketamine infusions for refractory chronic pain. Following that month in March, Dr. Wang will speak to us from New York University about optimizing ketamine to reduce chronic post-surgical pain in women. We're fortunate that through an anonymous donor that PARC will be again offering our PARC Fellowship this year. We're just starting to send the announcements out. They'll be due March 21st. This is a $100,000 award. So please use the QR code and consider preparing and applying. And also upcoming for PARC is our second annual Neuromodulation Symposium coming up April 26th, so save the date. And we have two plenary speakers as well as many UCSF faculty that will participate in that upcoming. Finally, it's my pleasure to introduce Dr. Brian Anderson, our speaker today. Dr. Anderson is assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. He's also an investigator at UC Berkeley Center for Science and of Psychedelics. He's a clinical psychiatrist and attends in the psychiatric emergency services at Zuckerberg San Francisco General Hospital. He's also involved in clinical research and a clinical trialist on both FDA-funded and NIH-sponsored programs, with a focus that includes complex interventions for patients who suffer from psychosocial distress in the setting of serious medical illness. He also focused on the harms of controlled substance use, as well as now focusing on how psychedelics can be appropriately used to improve the health and quality of life of various patient populations. So it's a real pleasure to then turn things over to Brian. Thank you so much for making the time. I will just finally add that if you have any questions and such, please put them in the chat and we'll get to them. So now go ahead and Brian, you can start sharing.
Okay. And thank you for having me and allowing me to present this talk, which I hope sparks some discussion and gets us thinking about psychedelic research and chronic pain. I know that last month, Dr. Josh Woolley, also in our Department of Psychiatry, presented on this topic, sort of more kind of an introduction to psychedelic therapy more broadly and how the research is done. So we're going to skip past some of that information and dive more into what we know about the use of psychedelics for chronic pain, the evidence or where the evidence is lacking. And so this is a review that I put together, not in a systematic way, but mostly to sort of help us think through where this field is at. Just starting with some disclosures. Obviously, we're talking about the use of some Schedule I substances, so they don't have any DEA approval. And then my research funding is here. As far as our objectives, so I hope that after this webinar, that we'll be able to describe at least some of the theories about how classic psychedelics could be helpful for chronic pain. We'll critique that evidence a little bit, examining what is in the published literature, and then we'll think through a little bit some methodological solutions for how to study classic psychedelics in trials. Before we dive into that, I just actually wanted to step back and think about the history of these compounds a little bit. And so anyone who wants to go off of mute and answer this, if you know it, go ahead. But I'm going to show some pictures to try to help us guess or identify what might be one of the earliest serotonergic psychoactive substances related to psychedelics, which affects pain, the experience of pain. I don't know if people recognize in this image, this is grain here, and there's these little sort of black-brown things growing on the grain. This is identified as a type of fungus known as ergot or Claviceps purpura, which it is thought that in the medieval ages, when people were exposed to compounds in this fungus, that they would develop a condition depicted here by an artist in the 1500s, where people experienced extreme pain, but also led to the loss of limbs. And folks with this condition were often attended to by folks of a monastic order dedicated to Saint Anthony. So any of this bringing up anything? I can't see that if there's anything in the chat. But unless anyone wants to jump in, ergotism or Saint Anthony's fire historically is diagnosed as a number of different symptoms that people can have when exposed to ergot alkaloids at high doses, including a burning pain sensation, hallucinations and paranoia, severe vasoconstriction leading to gangrene and loss of limbs and digits. And of course, ergot, this fungus, has led to certain medications that we have been used in the modern era for treating migraine, hemorrhage, but ergot is also the source of where LSD 25, lysergic acid 25, was originally derived from as a natural product. So the use of these substances and their effect on pain and perception goes back hundreds of years in the modern pharmacopoeia. What are the substances we're going to talk about today? There's a lot of different terms. This is a slide I've used in talks before, just to kind of break down what our focus is today. So this talk is about classic psychedelics. I want to differentiate that from what people typically refer to as hallucinogens. Hallucinogens, as it's used in typical sort of epidemiology, refers to classic psychedelics, but also other substances like entactogens, like ecstasy or MDMA. But that class also includes dissociatives, deliriogens like ketamine. But we're focusing on classic psychedelics today, of which you typically have compounds that are tryptamines or ergolines, so things like psilocybin, LSD, or some phenethylamines like mescaline is also included typically as a classic psychedelic. It's described in the literature that a common sort of part of the pathway, the mechanism of action of classic psychedelics is this predominance for their psychedelic subjective effects mediated through agonism of the serotonin 2A receptor, as well as, of course, a number of other receptors that they can connect to and affect. But what is in the literature most commonly repeated, this focus on 2A, is perhaps, a bit of a simple story. It's a story that I tell a lot, but, in preparing for this talk, I was pushed to kind of go back and think more about the mechanism of these substances. And if you go to this paper from 2010, that's actually really helpful in PLOS, where they used the National Institute of Mental Health's psychoactive drug screening program and reported on the receptor affinities for some of these compounds, DMT, psilocin, which is it's the drug that psilocybin rapidly is metabolized to after it's ingested in the body, as well as DOI, commonly used in preclinical studies as a psychedelic. You can see that the serotonin 2A receptor has, yes, there's some affinity for psilocin, but psilocin is actually has a greater affinity for the 2B receptor, known to have certain side effects like heart valvulopathy. The 1A receptor. So I think the story of this, there's agonism of 2A is a bit oversimplified, but it's still relevant. This is good for us to go back to our basic understandings once in a while too. Now, why focus on psychedelics, specifically classic psychedelics and chronic pain? Again, preparing for this talk and and some other work that our group at UCSF, myself, Jenny Mitchell, and others have been working on lately is there's been quite a bit more written about this topic in the literature. I have a list here just of reviews that you can find from the last several years written on this topic. It's really kind of exploded in interest. And yet, if you read through these, if you look at clinicaltrials.gov, you'll see that as much as there's an increased interest in the use of classic psychedelics for treating chronic pain conditions, we still only have 2 double-blind randomized controlled trials that have been published across the 2 of them, a total N of 28 participants, both conducted as single-site pilot exploratory trials at Yale University by Emanuel Schindler. So this is not to say that we shouldn't be interested or excited, but this is where the double-blind RCT, our sort of gold standard of medical knowledge for interventions, is at. And I think it's important for us to keep that in mind. I'm not a basic scientist. I really do focus more of my my research on clinical research and trials and other observational studies. But so I'll give sort of like a brief just listing here of the most common mechanisms, be they very biological up to sort of social and psychological, that are reported as promising or possibly relevant for the use of classic psychedelics for treating different chronic pain conditions. Certainly, we know that the serotonin system is rather important in nociception, both in and depending on which serotonin receptor and what part of the body. Serotonin may enhance the sensation of pain or may inhibit the experience of pain. This is already known, but what's interesting about classic psychedelics that again affect a multitude of different serotonin receptors is that they have been shown in preclinical models to enhance the density of dendrite formations. They enhance synaptic plasticity in different ways. They've also more recently, specifically DOI, again, a classic psychedelic or a psychedelic touted as being very 2A receptor specific. However, we know it also affects other receptors. DOI has been shown in preclinical, including rodent models of asthma and I think diabetes, to decrease disease burden through decreasing inflammation. And yet, if we go up to the human level, there's data from healthy volunteers as well as patient populations, not specifically in chronic pain that I'm aware of psychedelics, particularly psilocybin, ingested orally, having profound effects on brain functional connectivity. And we know that it has from self-report changes in that can be rather profound in mood and cognition, with the idea that particularly with chronic pain, we might be able to decrease rumination and catastrophizing after a psychedelic therapy treatment. What I find is interesting and maybe less commented on, but I think important for us to think through in designing possible interventions of classic psychedelics for pain conditions is their capacity to enhance the feeling of social connection that's been reported in both healthy volunteers and patient populations, particularly with mood disorders, and their possible effect of enhancing coping by assisting with meaning making is something we'll talk about a little bit more. But if we look at the full biopsychosocial spectrum of what we think contributes to chronic pain conditions, psychedelics may touch on a number of levels relevant for these disorders. To break this down a little bit more specifically and actually get to some data, and I do see there's some chat. Okay, you guys let me know if there's a question I should respond to more acutely. But breaking down just what some of the available data are, the application of psychedelics, both their use sort of out in the world in non-medical settings, as well as how they've been studied can range not just for the different types of psychedelics used, but also the dose. This is an important consideration. So focusing on what data do we have for very low doses of a psychedelic and how this may affect nociception. There is a study that was done with healthy volunteers published just a few years ago out of the Netherlands, where the cold pressor test was used, 24 healthy volunteers with prior psychedelic experience. And this is where they participants ingested the, in this case, LSD orally at low doses that were intended to not have the typical psychedelic subjective effects. It was blinded, and this was a within participant study. So there was crossover with 5 days between each session to reduce carryover effects. And then in the study, what they found was that participants could withstand keeping their hand in the very cold water longer when given 20 micrograms of oral LSD. This is a figure from their paper, but essentially their statistical test was the comparison of the different drug effect compared to placebo. And so when they measured the pain tolerance, how long they could keep their hand in the cold water at 1.5 hours and 5 hours after ingestion of the drug, with the highest dose that they studied, 20 micrograms of LSD, there was a significant difference compared to placebo. What this tells us is that when we compare this to, let's say, clinical trials where LSD is used as an adjunct to psychotherapy, the LSD is sometimes given in doses closer to 50 to 100 micrograms. So this is quite a bit lower than what might be typically used, and certainly lower than what's been given to humans in trials in the past, 200 plus micrograms. But this would be considered maybe like a microdose that people you probably have heard talk about taking on a regular day and maybe even going to work and being under the effect because it's subperceptual, but maybe having some effects on their body. If we go to not just microdosing, but a moderate dose of a classic psychedelic, what do we know about this effect on pain? Again, I mentioned that there are 2 published pilot trials focusing on migraine or headache conditions. And so if we just look at the results of one of these, again, this was only 10 participants, adults, who have a history of migraine. A requirement of being in this study was that they had to have migraines with a frequency of at least twice per week. And then in this trial, participants were randomized in a blinded fashion to either get an oral dose of psilocybin thought to be moderate, it's about 10 milligrams, versus placebo, with 2 weeks in between the 2 sessions. And the main outcome, the clinical outcome here was that these participants with a stable history of frequent migraines kept a headache diary for 2 weeks before each dosing session and 2 weeks after. The outcome here was that there were no serious adverse events reported. The study found this approach to be safe and feasible. And again, in a small pilot study, looking at placebo versus psilocybin, where the blind was most likely broken because of the psychoactive effects you can have even with a moderate dose of 10 milligrams, is that participants self-reported a significant decrease in migraine frequency compared to placebo in the 2 weeks after drug compared to the 2 weeks before. So we've talked about microdoses, moderate doses, and I want to show what we know about higher doses of using a classic psychedelic. I'm going to talk briefly about a series of studies that were done in the 1960s that are commonly referenced as a reason or rationale for studying classic psychedelics to treat chronic pain conditions. These studies, of course, were done before a lot of our good clinical practices and modern methods of trials were put into place. But I'll show you this because it is essentially the largest data set relevant to this question when conducted in a trial or a controlled clinical setting. So Dr. Eric Cast was a physician in Chicago in the 1960s. He was aware of this novel drug, lysergic acid diethylamide, LSD, that back then often in trials was not given orally. It was given as a injectable solution. And he approached patients in his hospital who had terminal illness. The vast majority of them had cancers, particularly metastatic cancers, but in his sample, there were some other patients with herpes zoster and other sort of infectious diseases that were leading them to have severe pain. And in these studies, the drug was administered after giving them a sort of a brief explanation that they were going to have a medication that could affect their pain. No talk therapy was provided before or after. They were monitored by the clinical staff in this hospital setting. But as a real divergence from the typical design of higher dose psychedelic therapy studies we see today, again, they were just told they were going to get a drug and that it could have effects, but they weren't provided behavioral therapy or talk therapy to try to support the safety or to enhance the effect of the drug. So what we know is that in the first case series published, there were 50 patients underwent this treatment, and then 128, and then 80 published in a series of articles or even book chapters is where I had to read some of this to understand what was done. If we look at the first study, it's kind of a complex design, but essentially patients with who were hospitalized who had severe pain were given either meperidine or dilaudid when they first reached out and said, I need something for pain. Then 6 hours later, if they had more pain, patients were given the other opioid. And then 6 hours later, if they had more pain and requested medication, then they were given LSD. So the timeline here is not, it's not like a parallel arm study. All participants, or the patients, I should say, got the different drugs at different times in sequence. But what they did is they rated pain severity of the participants, of the patients in the study, both by asking self-report of pain intensity as well as clinical ratings of like nurses that were on the unit. And interestingly, I think they even documented if patients in other beds made comments about the other person's pain, that went into this rating somehow. So the actual measure is a bit fuzzy, but think of it as a patient-reported outcome plus some sort of objective assessment of behavior related to pain. Showed that in my read, the overall sort of the total amplitude of pain relief is actually kind of comparable between the dose of meperidine and dilaudid and LSD used in this study. But what we see is that the LSD analgesia sets in a little bit later after administration and seems to last a bit longer as well. In this next graph, also again taken from Dr. Cast's publications, it's similar where patients were received intramuscular LSD with no psychosocial support. In this case, I think this was just an open label administration of the drug and observation of pain over hours and then days after administration. I bring this up in part because this data is sometimes used to argue that pain was improved for weeks after a single dose of administration. But I think it's important that we look and see that according to this rating, pain scores went almost back up to baseline within a couple of days after the apparent improvement in pain on the treatment day. But then they seem to decrease. But there's not a real explanation for why that might be or how consistent the data are at that point. But I think what we can say is that acutely, there is an improvement in pain, but what happens in the days after is maybe harder to interpret. And likewise, in this final sample that we'll discuss from Dr. Cast's data, it's sort of a similar picture where the hours, it shows that 10 hours after drug administration, pain is much relieved. But then over the next, 21 days that we see here, pain goes down and up, but it seems like it sort of returns to baseline kind of overall, though there may be points where the average amount of pain has been improved in these patients. I bring up this data for a few reasons. One, again, because it's often cited as a reason for why we should do this research in the first place, and it's claimed that pain was improved for weeks. I'm not sure if that's really the case. I think if we were to have the data on hand, there would be, I would have concerns about missing this. It's not really reported how many patients are included in these averages after the treatment. Again, there's no psychosocial support, or if there was some form of support in the hospital setting, it's not captured. This, compared to most of our studies today, is also different because almost all the participants in these studies were given Thorazine towards the end of their treatment in order to get them to sleep or sort of end the trip. And some of the participants actually had Thorazine during the experience itself if they had too much anxiety or agitation. So the effect of this antipsychotic medication on top of the LSD sort of confounds what we're seeing. It's not clearly reported in these manuscripts what the concurrent use of other medications was, other opioids that were patients were maybe receiving. And again, the measure here of pain intensity is this unusual, obviously not validated measure, but their best attempt from the 1960s to capture relief from pain. In thinking about data like this, and frankly, a lot of data that is still referenced in the psychedelic therapy field, we should acknowledge that there's a certain number of methodological challenges in using this data for really anything beyond maybe some safety and feasibility inferences. And I really appreciate this paper that was published by Charles O'Brien and actually UCSF's Rhys Jones back in the 1990s, pointing out problems of the earlier data, which again, I'm very happy that we have, and I find it fascinating to read, to think about like what we can learn from it. But in the 1995, they published this methods paper talking about how there was a lack of specific diagnoses or outcomes assessed in a lot of these studies, how informed consent was done was problematic. These trials often didn't have a meaningful control condition. Psychotherapy often was not standardized. They were recommending back in the 90s that we consider factorial designs, meaning the drug at different doses, placebo, active, low dose versus active, and then also low and high doses of the psychotherapy to understand that sort of influence on the outcomes, as well as blinded raters and requiring long-term follow-up of 6 to 12 months. What I find interesting is a lot of the papers critiquing the psychedelic research now are making these exact same claims and saying this is what we should be doing. But we have this knowledge that the science should aspire to this level of rigor for decades, and I think we're still catching up. Which is why I share this one publication, and for those interested in history, from Kit Bonson, who's controlled substance staff at FDA. She's a pharmacologist who reviewed a lot of the research with LSD published from the 1940s to the 1980s, and essentially concludes that, yes, we can make some inferences of safety and feasibility from that data, but because it was so often conducted outside of typical standards of methodological rigor for human subjects research, and also not even conducted with FDA-approved INDs, even though that was a requirement starting in the 60s. A lot of this research was not even in compliance with regulatory standards of the day. This is the data we refer to when we read these papers, and we should keep that in mind. So what data do we have? If, again, it's a lot of case reports, that there's that one cold pressor test, and then we have these older trials that we look to. It is helpful just to understand what our patients are doing and what they're saying. And so if we look at one survey that I found, which was published in 2022, and then a subsection of it was analyzed and published more recently. Here's an online survey of adults with chronic pain conditions who have some sort of prior psychedelic use. This is a survey of only 250 people who were finally included, who met criteria and completed the survey. Most of them were using or had used at some point in their life psilocybin and LSD, as well as some other psychedelics. This includes microdoses and macrodoses. And just to share, of the people who responded, the 250 included in this survey, not surprisingly, almost 2/3 of them have some sort of chronic back pain. Muscle pain was high, arthritis, sciatica. So my takeaway is patients that we're seeing in clinic may be similar to these patients who are using psychedelics and have these pain conditions. And so with this being our sort of table one, what can we learn from this study? A subsample of this 250 completed, again, these self-report assessments of how they think their use of psychedelics impacts their chronic pain conditions. And in this follow-up paper that was published in 2024, instead of just reporting all chronic pain, averaging across all these conditions, they focused on participants who specifically had fibromyalgia, arthritis. They also report on migraines and separately other headache conditions. But just to look at the data that are coming from this subsample, when asked to rate the typical pain relief that these adults get, for instance, in their fibromyalgia, looking at conventional or over-the-counter pain treatments, that's the white bar, versus the gray bar in the middle, that is microdoses of psychedelics, versus the dark gray bar on the far right is the amount of pain relief from macrodoses of psychedelics. So again, highly biased, online, somewhat small online sample of adults self-reporting chronic pain and psychedelic use. But in their quantitative assessment here, using a visual analog scale between 0 and 10 for pain relief, there's a stepwise function of perhaps dose of psychedelic, as well as that relates to relief from pain. Take that to mean what you will, but I think it's important to know that people out there perhaps are going to be doing this because they're reporting benefit and they're interpreting themselves as having benefit from the use of these substances. Now, surveys and these sort of case reports, this is all rather different from what we typically try to do in trials, where we really control, the medication, the context of the medication, meaning the psychotherapy or other sort of behavioral support that is given before, during, and after drug administration. And yet running these trials is complicated, and yet I'll say really enjoyable. It's something I love getting to do as part of my appointment here at UCSF. And this is a room that we set up at the old Langley Porter Psychiatric Hospital, where we conducted a psilocybin pilot trial a few years ago. You can see, hopefully from this picture, we really try to make the room warm, comforting, a place where people can feel very relaxed and sort of go into their experience, particularly at higher doses of a drug like psilocybin or LSD or MDMA, to sort of be as immersed in the subjective experience as they can for several hours under the supervision and guidance of our trained staff. And yet when you are wondering, why don't we have more trials? Why don't we have more research? I think it's just helpful to stop and reflect on the structural issues that go into making this data and why it's been hard to produce. Even though there's so much excitement and interest in psychedelics, and particularly in psychiatry these days, I think it's a good reminder that there was no conventional industry engaged in psychedelic medicine or supporting trials up until about 5 years ago. We didn't even have GMP or good manufactured product drugs when we did our pilot trial with psilocybin at Langley Porter starting back in 2018. We were using non-GMP drugs manufactured by an academic chemist in the Midwest. That's what we could get to do this research at all. And there was no NIH funding that was looking at the therapeutic uses of psychedelic medicines in trials until 2021. So this field is very nascent, and there weren't a lot of people who even wanted to be involved or who had serious concerns for a number of reasons up until more recently. Some challenges that I think the field is trying to figure out is that there's not a real sort of gold standard for what the type of psychosocial support should be in these trials. It's debated. We're getting empiric data on that now, but that is something you'll see quite a bit of variation. So when you read these trials, I would pay close attention to what that support really looks like, the training of the staff providing it, and the supervision that they got in order to implement it with fidelity. And from my perspective, there's not a lot of conventional experience, meaning amongst medical providers, and how to manage the types of adverse events that can happen. Certainly nausea, headache, et cetera, mild anxiety, that's fine. But when there are sort of persisting adverse events with psychedelics, like we've seen, particularly in community settings, we don't have a lot of experience of helping people through that. And it's something I think the field will need to work on as we have more experience in trial settings. Certainly the functional unblinding is a serious concern, meaning we give people the drug versus a placebo. They know they got the drug, and hence how much expectancy biases might affect the outcome, particularly in psychiatry, where most of the data is, where a lot of that is based off of self-report, but also in chronic pain, where we know that the sort of the psychosocial aspect of the condition can be significantly affect, what presents in clinic. And so that's something we'll have to deal with. And certainly these drugs have more of what, the FDA would call abuse liability, or what I'll term, non-medical use liability, even though the functional unblinding with psychedelics might be comparable to some other interventions we have. Those interventions aren't typically used in non-medical settings, particularly by youth who may be more prone to adverse events. And so that's part of our calculation of how we think about this data. I just wanted to bring this table up briefly, again, to hammer home this point that this field is still very young. We don't have barely any clinical trials with psychedelics in chronic pain, but even in psychiatry, these are the 3 largest studies we have published to date of psilocybin plus a behavioral intervention for a psychiatric or substance use condition. The largest study is 233 participants. That was just published a couple of years ago. Another one is 104 participants, and then there was for major depressive disorder. And then a third one published recently, an academic study of 95 people. This is our data set, our best data set for a lot of these drugs in mental health. And again, chronic pain is more nascent. On a more positive note, like what would I like to see now that we've viewed, what we have in the published literature? I'm very excited about the idea of targeting nociplastic chronic pain conditions. So conditions that seem primarily to conditions that are sort of primary chronic pain conditions that don't seem to be due to nerve damage or like a clear physical injury that we can isolate to, and considering both moderate and high doses of psychedelic drugs, as well as the behavioral therapy or talk therapy or physiotherapy that may go with the drug in order to treat these conditions. I want to highlight for the folks on the call today, 2 therapies that I'm excited about. I haven't gotten to use either of these, but in just reading about them and knowing one of the developers of one of these, both pain reprocessing therapy and emotional awareness and expression therapy have had positive trials published in the last few years for different chronic pain conditions. Pain reprocessing therapy was in JAMA a couple of years ago, found that in primary chronic, that's supposed to be chronic back pain in over 150 participants, whereas this versus placebo versus usual care was a positive outcome in pain intensity in that population. as well as emotional awareness and expression therapy, recently published out of the Los Angeles VA, where this is a bit more of a trauma-focused versus a cognitive exposure therapy like PRT. This trial published in older adults at the VA with primary chronic pain conditions, not just back pain, that they found that their treatment was actually outperformed CBT, thought to be a sort of a gold standard for a behavioral or psychotherapy intervention in chronic pain. And the thing that's nice about these is I think they can both work rather well with psychedelics. You don't just give a talk therapy plus a drug and hope that they go well together. You're going to have to, in the talk therapy before they get the drug, give them psychoeducation on the psychedelic, teach them skills so that they can tolerate the psychedelic better. And then after the psychedelic therapy session, in the days after, when you meet with them for more therapy, they are going to be processing the subjective experience that this possibly high dose of the drug led them through. You're going to have to draw on components of your therapy to help them make sense of their experience and use that to hopefully engage in some sort of behavioral activation, developing new, more positive behavioral regimens that can help them improve their functioning and lessen the impairment from their condition. I want to wrap up with just some thoughts and kind of other sort of next steps or things that we should be thinking about when conducting these trials or reading them. Obviously, with these small trials, it's going to be hard for us to do meaningful mediation and moderation analyses, but we can try to do that with observational studies, as has been done with psychedelics before. This paper from PNAS from a couple of years, 4 years ago is not a chronic pain population. This is a healthy volunteer study conducted with adults who have used psychedelics at art festivals, but they're able to get a sample size of over 1,000 and do the type of mediation analyses that I think we could translate into patient populations eventually, which is looking at, recent psychedelic use, how that may relate to self-reported, what they call transformative experiences, these sort of experiences of being outside of oneself and sort of changing one's perspective to oneself in the world, how that relates to social connectedness, and then the final clinical outcome or the outcome of interest, positive mood. If this can translate from healthy adults using psychedelics in the world to patients with mood disorders, that would be an interesting step. But also, this gives me reason to consider looking at measuring transformative experience as well as social connectedness for how those might mediate effects on chronic pain. And I just want to point to that this is out there and that we should be thinking about that for pain patients. And if you are interested in more real world or observational evidence, there's a strong movement about patient advocacy in this field. That's where, I've learned a lot from patient advocates and advocacy organizations that have been leading this field of psychedelics and pain to even do these studies in the first place, going back 20 plus years. So there's Psychedelics and Pain Association and a separate but related organization called Cluster Busters, focused on cluster headaches. They are actively looking for research partners for surveys and other studies, and I encourage you, if you're in this field, to talk to them about possible partnering. And just from a real world evidence perspective, I think over the next few years, we're going to see more clinical pilot studies focused on what does it look like to roll out interventions like this in a state, meaning not necessarily with the idea that this would result in FDA-approved treatments, but state-regulated access to psychedelics for adults, like we've had with cannabis for a long time. And now we have in Oregon and Colorado have state-regulated access to psychedelics as of the last couple of years. And I'm curious to see, even if it's non-medical, meaning FDA-approved, how might that be therapeutic and how we could measure that with research. If you want to know more about these changes in policy that are happening with psychedelics and state level and city level regulation, I would point you to a paper that one of our junior faculty in our group, Dr. Maha Mian, just published in the American Journal of Psychiatry, kind of breaking down these different frameworks of substance control for psychedelics. And I'll wrap up by saying that here at UCSF, we are just now starting to recruit for a clinical trial that's not specific for chronic pain patients, but this is a trial of psilocybin therapy for psychological distress, or specifically demoralization, in adults with a life-threatening medical diagnosis, of which we have a pre-specified subgroup analysis of patients with moderate to severe cancer-related pain that we're going to, once the study is done, try to see if we find any sort of signal of the different types of, obviously, cancer-related pains that people can have, but is there some possible benefit in this population? And if you're interested in knowing more about this, or possibly referring your patients who are adults with life-threatening illness and a limited prognosis, please refer them to us. So to summarize, our literature is mostly case reports still. We should be mindful of that. There's multiple possible mechanisms that align with the biopsychosocial framework of chronic pain. And yet, to do these trials that we need to do, you have to think through the design rather carefully. But don't get too hung up on that, because your patients may be using psychedelics for chronic pain now. And if you're interested in interventional or observational research, there's many more opportunities, and I encourage you to consider getting involved if you are a researcher, a patient, or an advocate. So thank you, and I will stop sharing my slides.
Great. Thank you so much, Brian. That was so provocative. We're open for questions. I'll just first direct folks to the chat that there is a reference to a video to review, I believe, some historical accounts that went to everybody, but also a little bit you touched on what the possible mechanism for decreasing pain with psychedelics. I don't know if beyond when you mentioned about the serotonin receptor subtypes, do you have any other comments about what speculation is for a particular type or subtype of psychedelics and related to decreasing pain?
Yeah, so I see Dr. Smith's question about mechanisms. To spend, yeah, I went over that pretty quickly, but to focus on that, these preclinical data, again, mostly in mouse models right now, looking at particularly DOI to decrease inflammation, to inhibit the TNF alpha pathway and other sort of interleukins, is very interesting as a way to think about lower doses of psychedelics that don't need to have the perceptual psychedelic effects, but to prevent or maybe even reverse these evidence of disease from inflammation. So you would think for someone with some types of arthritis or other immune-related pain conditions, low doses, possibly even used at with some frequency, might be an intervention of interest. And yet, that is just different from recognizing that this is not my area, but I know people at UCSF have studied this, the descending inhibition of pain signals that come from the brain down to the spinal cord that are mediated by different serotonin receptors, could have a number of different ways that psychedelics would affect them. But again, psychedelic drugs, depending on their dose and what receptors they have particular affinity to, they're a complex story. So some are very particular for serotonin 1A receptors, some are more serotonin 2A receptors, and then some also hit the 1B and 1D receptors that some of our current triptans we use for headache medicines target. So I think just the story is very complex, and it'll depend on the pain condition and the psychedelic studied.
Great. Brian, there's a few more questions or comments that came in. One from Andy Tompkins is, have you thought about what would be a good outcome from a chronic pain RCT? Is it like trying to reduce opioid use or improving mood or reducing pain interference? What have you thought about that?
So yeah, depending on the pain condition used, we could think of some of these. I didn't mention it, but I had it on one of the slides that I think pain interference. I mean, one just such like a gold standard, like how are you functioning even with your pain is great. And I would like to pursue that as a primary outcome, in part because of what we see in mood disorders, where we often have patients say, I continue to suffer, like my mood is bad, but it doesn't affect me as much. I'm still able to have my low mood, but engage with my family or go about my day. And so it's the interference or the impairment of the symptom is alleviated. Um, and if we can see something, if there's an analogy in chronic pain, or even if it may not go away, but you may improve intensity some, but the interference, I would love to focus on that for our patients.
Great, great. Lawrence Paris was just asking about relative risk of addiction, like between psychedelics versus opioids. What's your thoughts on that?
Great. So I didn't touch on that really at all. Focusing on the classic psychedelics, not including the psychedelic stimulants like MDMA and other compounds. Classic psychedelics really don't have the abuse liability like drugs like opioids, tobacco, alcohol that can really lead to dependence in a pretty strong way. However, again, I mentioned that, there is abuse liability, which often is defined as people using it in non-medical ways. So you may have strong feelings about what's appropriate. Is it abuse or not? If it's not medical, but the use of classic psychedelics like psilocybin, which is in psilocybe or magic mushrooms, LSD, does not lead to the type of dependence that we see with other habit-forming compounds, but they can lead to other problems in your life for sure. It just we don't see hallucinogen use disorder that often, where I think we're more likely going to see when you have an adverse outcome from use, it's going to be a psychedelic related psychotic or mood episode or other sort of acute behavioral danger related to the acute effects and not an ongoing dependence problem.
Right. Our lead pain psychologist at our Center for Pain Medicine, Valerie Jackson. Valerie, maybe you could unmute your Zoom and can you do that, or do I need to
Yeah,
do that?
hi.
Yeah, yeah.
Hi, thank you
Maybe
for
I didn't want to butcher your question. Why don't you go ahead?
yeah, thank you for an excellent and just incredibly interesting talk here. So I use PRT. I'm certified in PRT and to a lesser degree EAET in our clinic, and I really can see how those would work well together with psychedelics. And I just wondered where in kind of the research pipeline does you touched on it? Where does that fall? Like when will that actually happen? Some kind of work with PRT or EAET?
Well, if our group, which is part of a large consortium, including University of Colorado, where a lot of the PRT work has been done recently, if we're funded by the NIH, we will do a PRT plus psilocybin trial in the next few years. But regardless of whether we do it or someone else, specifically the part of sort of the exercises for interoceptive awareness and sort of bodily awareness work that you can do with PRT, we already do a lot of that in psychedelic therapy. We do a lot of sort of like focus on breath, on where attention is, and there is this thing that happens where under the effect of a psychedelic, people kind of maybe it's related to synesthesia or other processes, feel their emotions in these like physical ways, and your sense of connection and just overall awareness of your body can be different acutely and sometimes for days, if not longer, after. And so as far as like a theoretical linking, uh, do psychedelics not just sort of recalibrate mood or rumination and cognitive patterns, but can they be used to recalibrate sort of bodily awareness is something I think is really compelling. And there's a really nice theoretical piece by Ho et al. Published in 2020 that I'm happy to send you, Dr. Jackson.
Yeah, I'd
Kind of
love that.
like breaks that down. So I'll try to connect with you later about that.
Yeah, wonderful. Thank you.
Great. Let's see. There's one maybe time for one last. Oh boy. So maybe Tess could unmute and
Oh,
briefly provide
um,
the question. Thank you.
Hey, Brian. Hi, a lot of other people. I'm a neurology resident at Stanford and incoming pain fellow. I was just wondering, I've heard from some like pain patient communities that they really want one day for there to be an approved option for psychedelic treatment for pain, but without therapy, in part because that's how it's kind of been developed in the wild by cluster busters, more specifically for cluster headache. And I don't know to what degree people think that will generalize to kind of non-headache pain conditions, and headache is more of an episodic disorder. There's lots of features about it that are different. But I was wondering, Brian, how you think that will play into kind of psychedelic trials for pain overall? Like, will it be that first it will be with therapy and slowly it'll transition out, or there'll just be kind of different schools that do it in different ways? And what's like your opinion on the safety of that?
Um, for, you know, I said that in the Schindler trials, the 10 milligram dose was a moderate dose. We actually have used that in other trials at UCSF and Berkeley sometimes. And people have psychoactive effects, and people report to us, they had like a lot of emotions that came up for the next few days, but they can sort of tolerate it. I think it could be certainly safe when used in like a supervised way for medical purposes to do that without the extensive talk therapy. More importantly, people are going to Oregon now. People are going to Oakland now and going to dispensaries and getting psychedelics. Like, this is happening already. And so from a safety perspective, knowing that people will probably use this most of the time, 8 million people use hallucinogens every year, according to SAMHSA in their NISDA survey, in the United States. Most of the time, people will not have this extensive psychotherapy battery that goes, or, regimen that goes with it. And we as clinicians could talk to them just about like basic safety things that will probably improve their safety, even if they're not going to go do this in something that emulates an FDA regulated trial.
Well, we're at the time. Thank you so much, Brian. And just to remind those that may have come in late, we will post an archive of the talk for your access and reference. But again, thank you so much, Brian. It was very stimulating and hopefully generate some new collaborations for you. All right. Take care, everybody.